The doctor is in, finally.
Are we? Are we in? We're in. I love it.
We
Good
had a rough
evening,
day
everybody.
today, you guys. We've been trying to get in since 6 o'clock. Hello, it's 6:20, but we're here.
It's all good.
Facebook was not in our happy place today. So,
Well, and you know what? Sometimes the metaverse is, sometimes the metaverse isn't.
right.
But we have an amazing show, an important
do.
topic today. We're talking about one of our favorite things to talk about, the thing that matters most in our universe right now, and hopefully in the metaverse and everybody else's universe, clinical trials. So,
Right. And health
the doctor
disparities, We are talking about have we moved the needle on health disparities, on clinical trials, on everything? And we have our amazing guest, our amazing, brilliant, bodacious, phenomenal, like, what can I say about this, like, super meta thriver, badass Jamil. And we're so happy to have her. You know, she is the CEO of Chrysalis. She's the chair of the board of Metaviver. She's on the board of LBBC. What else are you? She's everything in breast cancer. And you know, she's a relatively new breastie. Well, 3 years, 3 years?
4 years.
4 years, okay.
Yeah,
Guys,
4
you're a
amazing
frontline
years.
girl every day, frontline girl every day. She's a mom, a wife, a professional, like, you know, badass worker person. Like, she works every day really hard. And then she
America. Yep, she does it all.
She does it all. Her purple cape weighs about 40 pounds and she wears it with grace and she's phenomenal. So, and she's like in the trenches fighting this disparity fight every day. She's totally, it's become her purpose. And so I can't wait to talk to her about this topic, but we, you know, we keep talking about changing the game, and, you know, George Floyd this, and health disparities are now on the table, and, you know, like, let's fix the Black people, and the whole COVID thing, and like all the stuff is there. We're all talking about it, but what is actually happening? What is being done? Where are we making an impact? Who's making the impact? And where should we try to make people go to get this done? Because it's like in our face, you know, and you know, let's start talking, Jamal. You talk about you know, what is racism? I mean, it boils down to racism. It has not gone away. It's maybe taken a turn, but people who
Still there.
don't want to admit it, right?
Right.
So then what is it? Is it implicit bias? So what is it? Because people are still getting sick. They're not getting the care that they need. And these issues just still aren't being addressed to my satisfaction. Right?
Yeah, let's backtrack a little bit and we can define health disparities. I want to say, first of all, I'm honored to be in this particular audience here today with you two wonderful people, because I have the privilege of serving on your medical advisory boards for both of your wonderful organizations that operate in very different and impactful and powerful ways.
Right.
And it says something when you can put folks in a room together and at the table together and have these types of conversations in a really synergistic way, because there is so much room at the table for all of our organizations, all of our efforts, all of our leaders to come together and address these types of problems. So, you know, Jamil, I know, has an amazing health equity initiative through the Chrysalis Initiative, and you probably can help us with some basic definitions, because it's stuff that we hear, but I think we should make sure that people know and get us all on the same page. So when we say health disparities, what does that mean to you? What should that mean to the average person watching?
Well, thank you so much for having me. I'm honored to be on this panel as well. And when we think about disparities, it is a particular group of people where they are disproportionately impacted by a disease or illness, or whatever the instance is, disproportionately more so than the average or the norm. And there are tons of underlying reasons as to why that may be. But when we're thinking about breast cancer and the disparity that is prevalent and has been prevalent for quite some time now, whereas Black women are dying and succumbing to breast cancer and being diagnosed earlier and at later stages, more so than other groups, and dying at a much higher rate, so 42% higher than white women in comparison. And so why is that? And I think for a long time, we've thought about, oh, it must be due to poverty, social economic issues, the fact that Black women disproportionately don't have access to quality care or don't have access to insurance. And then we've also heard that it's due to molecular differences, lifestyle changes. Because of the impact of those social economic pressures, that's the reason why, you know, they don't have the same level of care. However, I think that just nationally, it's great that everyone has put so much focus and attention on this. It gives us an opportunity to really point it out and say what we traditionally have been doing to address these issues hasn't been working. And so acknowledging that a lot of this is still due to that structural systemic racism that have established these systems of care and resources and insurance and health systems. When you have just the layering of barriers that were specifically put there as barriers for a specific group of people, there's going to be consequences to that and consequences that impact care. And so under acknowledging we still have an issue, acknowledging that it's multifactorial, it's not just one thing, and then we can actually use evidence-based solutions to address it. So I am encouraged by the fact that there is so much amplification and attention to it. What I hope we don't do is squander the opportunity to, okay, let's actually go with what works and not just invest in what's safe or what, you know, we can get approved easily, but really say the racism part out loud, acknowledge that a lot of these structures were built on racist principles and it's been layered, you know, over year after year after year.
That's where we have to start. In my humble opinion, you're absolutely right. When we say the term structural racism, I don't know if everybody understands that, you know, but there are social determinants of health and there are the structures of our society, our hospitals, right? Our legislation, our transportation, our housing, federal systems, education, these are structures. And what we're saying are that these structures were designed to create and to perpetuate disadvantage. So in the healthcare system, for example, the way that healthcare is executed was structurally designed. It was from our very arrival, before we got to these shores, right? From slave ships, doctors were placed on slave ships in order to keep slaves alive long enough to be sold at the block. So the relationship between our people and physicians and the healthcare system and the structures that determine how healthy people are, what food they get to eat and what hospitals they get to use, what access they have. These structures were in place. And the reason it's important to say that out loud is because when we say the word racism, Ricky, you had a really good analogy earlier. It's like people who drink but don't want to admit they're an alcoholic, right? It's like, there are degrees for sure, but without, you know, but there is such a burden and a heaviness and a guilt that comes along with calling a thing, that it's important for anybody living in this day and age to understand that these structures were in place before we got here. And that should empower you now to be able to make changes in the structures, not just your personal attitudes and your personal behaviors, but it changes in the actual structures that determine how people live and survive and thrive and do research. And so that's what we mean by the whole structural part of things. And then Jamil, you said something else, right? Like you hit the head on the nail when you say moving the needle forward. So where is the needle now? Where's the needle, Ricky?
The needle now is we've made some strides. We've acknowledged that there's an issue. I think it's now societally accepted, and even just nationally within cancer centers, it's accepted that, you know, we have disparities. We have disparities in treatment. We have disparities in outcomes when it comes to Black people, in particular, Black women with breast cancer. We know it exists. So there's the acknowledgement and recognition that it exists, for one. Secondly, what does it do to? We know that we can tie it back to disparities, you know, specifically to access to care, access to quality treatment and insurance, even just recovery time and support resources. And why are there these gaps when you think about the holes in the continuum of care? What are the contributing factors? It's easy to look at a lot of these different metrics and indicators and say, you know what, they just didn't have or they couldn't access. But we have to also do a deeper dive. And that's where we move the needle, right? Because we've been kind of in this stagnant posture right now with saying, okay, well, if we just improve access or if we just improve income, knowing that if you think about just the hundreds of years where these structures were built, even when you think about just where hospitals are located and where the most funded hospitals are and who's receiving care where, that ties back to the history in this country from redlining and where resources were available. And then thinking about Medicare and Medicaid and how hospitals were integrated. So just if you have all of these structural racism and systemic racism going on, it's almost like it's a socially transmitted belief. So that bias is inherently.
I love that.
Ooh, STB. Okay.
I love that. I love
so
that.
It's hard to say, you know, I am just absolutely immune, even if you don't believe that there is anything inherently inferior of Black women or Black people. But if we are the other, if our lives are not valued, just a great example, for instance, where pain is not managed properly, recovery supports are not provided. And these are usually measures of care that are initiated by practitioners. So if a practitioner has the belief that a Black woman is not going to participate in a clinical trial, or does not need, or is not going to be able to afford that additional nurse at home in order to recover properly, or thinks that it's above and beyond to connect them and do that warm handoff to provide them with those support resources so that they can adhere to their treatment better, or doesn't do the follow-up and if there's a missed appointment. Just those little measures in a continuum of care can make that much of a difference. So if it's based off of the individual biases that someone could be harboring unbeknownst to them, that can impact someone's care substantially. Just, you're basically taking out the reinforcements in that foundation and it's going to crash, you know, because of how, I mean, we're human beings. I mean, bias is a normal thing, but the only thing in order to move the needle is to have those checks and balances in place to say, you know, this
something's
is our
not right.
intention.
Something is not
to
right.
be equitable in our care, but you can't just assume that people are going to do the right thing. I mean, that's great to assume that people are going to do the right thing, but in order to prioritize equity in care and treatment and outcomes, you have to have those checks and balances in place. And so that's how we move the needle, by not saying, you know, we're just going to take care of this or this one part of it, but have it be comprehensive, have it be where, you know what, if this is important to us, and I love the fact that we do have, you know, cancer moonshot and the mama bus bill, you know, for maternal health disparities. It's the same thing, literally.
Same thing.
Checks
So
and balances
you know
in
what,
place,
Jamil?
prioritizing investment.
So Jamil, you know what? Monique provoked me to, or influenced me, or motivated me to define health equity, right? So, you know, I learned this from her. Like, the first thing she says to a new patient is, I'm going to treat you like family. So to me, health equity can't be achieved until every doctor says, I'm going to treat you like family.
I don't agree with that, because,
you know, I think they have to.
I don't think that we have to have a doctor.
It's an interesting surrogate. Right.
Right.
Go ahead,
I don't
say that
think
again?
a doctor has to go over and beyond to provide quality standard of care. I could care less, actually, if you don't care about me, but there should be some measurement in place or some accountability, checks and balances in place for this institution, you know, in order to provide quality standard of care. If you don't like me, that, you know, if we don't vibe, you know, because that
we don't like all our family members.
Oh yeah. It's not even about that. It's not even about like, but it's saying, I'm going to.
Saying I see you. It's saying
I see you.
It's saying that I see you.
And I'm going to treat you with the best care possible.
And it's not a surrogate. Let's be clear. You know, saying to a person that I see you and that I'm going to treat you like family doesn't mean I'm going to give you preferential treatment. It means that I'm going to, and this is where it gets tricky, Jamil. You're right in a sense, because for our family members, we can get paternalistic, right? We can think we know what's best for our family members. We can get, you know, We can get overprotective for our family members, which for a patient isn't necessarily a bad thing, but it can be when paternalism turns into, I'm going to do what I think is in your best interest. And I think that's where the checks and balances comes into place.
Right.
But, you know, Ricky, what I hear you saying about what equity means and looks like is when you tell a person, I'm going to treat you as if I would treat my family, meaning I'm going to ask the questions that I would ask if I were sitting in that seat over there. I'm going to answer those questions for you. I'm going to explain things in language you can understand. I'm going to make sure that I consider all of the different factors and not just the tumor, but the person and the ecosystem attached to the tumor. Those are important things, I think, for a patient to hear to help them to build that relationship with that provider. But it's certainly not the sum total of what with what equity is. And so I think you're not wrong in saying that it really has to do with the standard of care. And Ricky, I know I owe you this video. We're going to do it and get into what the standard of care is. I have not forgotten. I'm so bad with, believe it or not, with videos. And I owe Jamil 2 videos too. I haven't forgotten. Neither here nor there. But what I'd like to insert here as we talk about, you know, where the needle actually is and what it takes to move the needle. As far as cancer clinical trials, less than 3% consist of Black women, not just Black and brown lumped together, but Black women, less than 3% in clinical trials. We know that 80% of Black and brown women get their Black and brown people as a whole get their cancer care at community hospitals. Yet 80% of the research is not done through those institutions. And I would love to insert and begin to talk about, you know, the inequity that results in the disparity in cancer research just through that mechanism alone, right? The structures that are in place in community settings that preclude patients from participating in trials at larger NCI designated at the university hospitals, et cetera. And I think that we need to, as we examine where the challenges are, you know, as a physician, I can tell you there's not enough research and emphasis placed on research in medical training, right? We're at the point now where it's getting, you know how high school is like, get to the test, pass the test, get to the capstones and whatever else, whatever those milestone exams are that you got to get to in high school. And they teach tests. Medical school is rapidly becoming that way. And we're now refocusing to try to focus on the patient. But for a while, it was pass the boards, pass the boards, pass the boards. It wasn't about how can we move the needle. It wasn't about exploring where the challenges are. You just learn the volume of information. And there's a disconnect even from the patients in the medical schools. When I take patients to schools and put them on a panel and just sit them in front of students and say, tell your story. The number of students that come up and relate to it afterward and say, now I get it. Now I understand this chemotherapy drug because I saw what it did in a patient. And now I can relate the cisplatin and the pathway and the this and the that to the person sitting in front of me. So there's a really fundamental disconnect that happens even at the level of training, right? So we got a lot of holes in the pipeline, a lot of things to fill.
Right. Can I add one more element too? So Dr. Agori, one of our other medical advisory boards, sent me this article this afternoon, Mo, and it's new research from Sanford Vernon Presbyterian has revealed, I've been waiting for this research, has revealed a significant molecular differences between the breast cells of white women and Black women that help explain why Black women experience higher breast cancer mortality. The findings published February 8th, yesterday, in the journal Therapeutic Advances in Medical Oncology suggest that changing current diagnostic and treatment strategies could help address the disparity. So I've been waiting for somebody to really validate the fact that Black breast cancer is different. And so add all of this bias and racism and access and all this stuff on top of the fact that our disease is different and it needs different treatment. And it's even messier.
Right. I think it's, you know, I'm encouraged. We do need more research of Black women and Black bodies, and for us to understand how we respond to treatment, and just on a molecular level, you know, which proteins are expressed differently, and what are those differences, how it can be treated more appropriately. But again, I don't want that to be it. I think people still have to understand that it does take a comprehensive multifactored approach. It's not just one thing. So
Right.
even
Oh, yeah.
the same way
not.
that studies have revealed that we respond differently to chemotherapy, we respond differently as far as side effects and neuropathy.
We get more
that we tend-
neuropathy, we get, right, all
heart
the stuff.
toxicity, side effects. And so that has
And we're
changed.
dying at a 42% higher rate.
And even the comorbidities, right? Diabetes, high blood pressure,
Right,
we
right.
understand, but that is already almost baked in the cake. So the more information that we have, yes, that's going to improve the care and treatment that we receive. I think making sure that meeting barriers, intervening and providing, making sure that we can at least receive the standard of care, right? Meeting those gaps and doing what needs to be done to intervene to at least have baseline, right? Baseline, not Swiss cheese standard of care, meaning those gaps are filled. And then also making sure that we study and understand how it is different. Why is it that we tend to be diagnosed younger? Why is it that we metastasize sooner? Why is it that we have these DNA repair differences in that particular with hormone positive breast cancer? Why is that? And what do we do as a result of that? But not to say, okay, this is it and it's only this one thing. It's not just poverty. It's not just social economic
everything.
It's very
not just
it's
biological
everything.
differences.
It's very complicated.
And it's not
very
just racism, but they're all contributors.
So let me ask you this then, for the person who's watching, who's newly diagnosed, and they're trying to figure out what to do, where to go, am I at a good center? How do I navigate this thing? What are some warning signs for them that they perhaps need to reevaluate where they're being treated, or if their spidey sense is tingling? How do they give word or give credit to that? That's not just trauma informed, right? But actually informed by something. How do you know if you're getting poor care? That's the first one. Suboptimal care or biased care. How can they tell? Because I know we have checklists for how can we tell if institutions are doing, but for the person in that exam room, in that gown, naked underneath, how can they tell when the care is not great? And then the second question is, how can you tell when it's good?
Well, I'm going to say go to bcnavi.com and get the app so that you have the standard of care documents to refer to.
Say that again, Chelsea. Say your app again, and let's put it in the chat.
I'm putting it in there.
Okay.
BC Navi.
Yes, bcnavi.com. And you can have a reference guide based off your subtype, based off of your stage. What to expect? What is standard of care? What is it if it's different? What are the tests that you should be receiving at this point? That's like baseline standard 101. But I would also say, pick up on those social cues, those bias cues, right? How is the posture of who you're talking to? What are the waiting times when you go in? Are your questions being answered?
Don't go by the wait times. Flag on the play.
Says the doctor.
I think wait times.
Says the very
there's a difference
doctor.
There's a difference between, because I know I wait for my doctor too. There's a difference between a doctor who takes that time with every patient because she's treating them like family, right? Or a patient that does not get to see their oncologist, or does, or gets the runaround.
The hand on the doorknob, right?
No warm hand off, no understanding of what
never release the hand on the doorknob. You wait an hour and a half, and then the doctor spends 2 minutes with you, and you're like, wait a minute.
Right. There's
definitely
a sign, right?
Avoid the doorknob sign.
Yep. Right. There's definitely a difference there. What is the posture of the person that's engaging with you? Are they making eye contact? Are they talking to you and with you or at you? Right?
Do they embrace your family? Do they embrace your family? Do they ask you how you feel about and how your life is going? Do they
are they being dismissive when you have a concern, right? And so those are all some of the different cues that can kind of tell you, are you valued? Are you going to be in good care? Are your questions being answered?
Okay, let me interject. Those are very subjective things, meaning, do I feel warm and fuzzy when I go to this doctor?
No, I don't even think you have to feel warm and fuzzy, but they should acknowledge that you are a person. And that's why I say, I don't know if I expect everyone that I engage with to treat me like family, but I do expect that you respect me enough to treat me as a person. And that humanization is needed because, of course, that's going to let me know that they're going to take care on my side effects and listen. Or even when we have so many Black women that are not even told about the implications to their fertility when they go into treatment. Why is that? Why is it readily given to white women when they go into, treatment, and they're letting them know, do you want to have a fertility consultation prior to starting treatment? These are the implications. But with Black women, it's not, it's missed so many times. But it means that they are recognizing that this person is a human being with a family who is important to other people. And that bias can inform what treatment options are even provided, what support resources are provided,
Right.
and it impacts how they're going to fare once everything is said and done. So I think most people are surprised on how a person who is harboring bias has the autonomy to really make or break someone's path on this, to get care, just because of the fact that they're either withholding information, not connecting them to the right resources. And that can have significant damage to how this person is either going to survive or not. It really can be the reason why you live or die. And it's just that dire. And so patient clinician communication, I hear from oncologists all the time, well, what is the reason why these particular patients were not provided with these resources, or not provided with this testing, or this wasn't checked? And they say, well, you connect with some patients more so than others. That's
Right.
not acceptable.
No.
Even if you can't stand me, right? You should still have at least baselines to meet the quality standard of care. But recognize that I'm a person, but you have to, pull in tools, pull in that support. I think we're at the point now where we understand that we can check our biases and understand if it's influencing. But what's great is that we have data. We know that we have patients that are Black and brown that are not receiving the typical standard of care patient experience that they should be. And we can unpack where those breakdowns occur.
Right.
And then you can course correct and make sure that those gaps are being filled.
Now that's really interesting, the patient experience, because the standard of care and the patient experience are often two different things. And rarely do they intersect, I'm going to say, in truly positive ways, because the standard of care can be confusing. It can mean more tests. It can mean more copays. It can mean a lot of different things that doesn't necessarily make for a great patient experience, especially at a time when you're trying to get rid of your cancer. You want to know if you're going to live or die, and try to figure out what's going to happen to your family. And so I think it's important also for us to circle back on some of these issues, Jamil, because I talked to my hospital support group just on Monday. We talked about sex and intimacy, and we talked about survivorship and some of the side effects of what they're going through. And one person said, man, I wish I'd known all this at the beginning of my journey, because my mind is open and And the other person said, I don't know. I don't think I would have made it if you told me all this in the beginning. I don't think I would have been able to digest all of this in the beginning. People are different, and it's up to it's up to that white coat to figure out how to navigate all of these things, but to still offer that clinical trial, still offer that the financial navigation, still offer the plastic surgery consult, still offer the reproductive consults, all the things, right? And I think that it's important for patients, for family members, people watching right now. If you know somebody who's going through this cancer journey, get the right resources so that you can be able to look at a list and check the list and be able to say, did you get offered this? Okay, did anybody talk about a trial? Even if you don't want a trial, did anybody mention the word clinical trial to you? Did anybody talk about, physical therapy and range of motion? Did anybody talk about nutrition with you? Did anybody, and be able to go down that list so that you can understand where you fall in all that stuff. Because if it's left up to you to remember, right, for you to jot down on your notes, our minds go blank.
It's all like,
mine goes blank when I sit on that bench, right? My brain is like, what was I supposed to ask that? By the time they walk out of the room, I'm like, oh yeah, I forgot I was supposed to ask this. And so,
there's a lot of pressure and a lot on health systems at this point. So I know that there's a lot as far as just the patient portfolio of nurse navigators and patient navigators within cancer centers. So it is a lot, but that's also the beauty of BC Navi, is that we connect them with breast cancer coaches that are with similar lifestyles, similar treatment histories, and they know what to help them understand. And we go over it over and over and over again. So meaning we're checking and assessing and tracking how you're doing in all those care tracker elements, so that you don't have to remember all of this on your own.
And let me ask you this, is this for metastatic or for early stage or for all stages?
All stages.
All stages, all
Beautiful.
stages. I went with a patient 2 weeks ago, Gwen, she says, Gwen McKinney, she has stage 0. If you're gonna get breast cancer, that's what you want, right? But I went with her to her surgeon consult, and even someone at stage 0 has a lot of questions, has a lot of fear, and so she needed me to hold her hand. And she wanted me to go to the doctor with her, which I was happy to. So it doesn't matter what stage, it's still that C word is frightening. And you guys, we should probably put in the comments, the guide that we did for More Than Just Words. Together, we were all working with Novartis on the More Than Just Words campaign. That's how we got Jasmine Sullivan on the show. But yeah, the guide that you did, no, I forget what it's called, but we should put that in the comments.
Okay.
Because
I'll definitely
give you a really good tool of what questions to ask your doctor. And
it's true.
Conversation.
You should walk out of your doctor's appointment understanding if you're there for benign reasons or for workup for something, you should understand what your exam is, right? What your imaging showed, or if you didn't have imaging, what imaging you need, what you should watch out for at home, when's the next time you should check in about these things. Like there's so much, and your family history. Somebody should be asking about your full family history to the best of your knowledge and giving you the words to start to have that conversation with your family if you don't know that history. If you got nothing and it's a blank, but you're not adopted and you have family, but nobody's talking about it, it's up to us to really start to help you have that conversation as well.
Yeah.
And it's a hard thing to get into one clinical exam room meeting, but you should at least leave with a couple questions on how to ask your family about the cancer history, right?
Yeah.
And if you do have a diagnosis, you ought to walk out of there knowing what your diagnosis is, what's your stage, what's your subtype, the hormone receptors, the ER, PR, the HER2, the the PER, and the HER.
It's complicated.
It's complicated. You should know what surgery you're getting and why. Right? What you're not having and why you're not having it. Because somebody's gonna say, but I have stage 1 and I had to get chemo. Why don't you have to get chemo in your stage 1?
Right.
Why are you getting mastectomy and I got a lumpectomy? Everybody's cancer is different.
Absolutely.
Right? You should walk out of there with a plan for how to begin to improve your nutrition and get yourself ready for your surgery or your chemo or whatever therapy you're going to have, what to watch out for at home, and who to call with questions, because there's a contact person in every single cancer program. So for folks who are watching, just to recap, because we're now like 40 minutes in, this is the Doctor's In, where we talk every Wednesday about cancer and about cancer patients. And right now we're talking about moving the needle for health disparities. And one of the disparities, of course, is health literacy. So now we're talking about what do people know and how do we get our community literate enough to be good advocates and to sit in that seat and ask the question. So Jamil, my question for you, and Ricky for you, family members who are watching who don't know anything about cancer, but they're sitting in these appointments, how do they get educated? What should they be doing?
Well,
I love this. I love you so much, Jamil.
Well, I guess for us, the way that we look at it, it is so multi-pronged. So in order to address disparities, so we do caregiver coaching too. And with BC Navi, you can have your caregiver have access to your care tracker and how you're doing, so all of those different elements that we go over all the time, because it is complicated. It is really complicated as far as just what are my biomarkers and my stage. But the one thing I would say and take away that I think we understand now in 2022 is that once you have breast cancer, you have breast cancer. It doesn't really matter the stage. Doesn't really matter. It's a continuum. So if you're diagnosed with stage 0, guess what? You're going to be having some type of maintenance monitoring. This is part of your health
for the rest of your life, right?
Exactly. And I think most people think, we make sure that they understand that you're not done, even after you get your treatment. So I think providing them with that information from the get-go prepares them to be empowered to start understanding all of these different aspects and how it applies to them. And then that way they can share that with their daughters, their sisters, their aunts, and also family members and their caregiver to let them know, well, this is the type of treatment that I'm on now. This is why I'm doing this. And and but there's so many resources available. And that's the other thing that's available on bcnavi.com is when you log in, all of the links to all of the resources for you to learn about your specific type of breast cancer. And even if there's a change down the line, did you have a recurrence? Did you have progression? Is it the same subtype? What questions and tests do you need to get?
Let me pause you right there and hone in on something really important that you just said. You said, what if your breast cancer changes?
Yeah.
Right?
Yeah.
Because I think that most people don't even know that your
Right.
subtype, the type of cancer you
Can
have, can
change.
change. You hear the word
Mhm.
cancer, they think, well, number one, it's one disease. And I'm here to
Right.
tell you that cancer is not one disease. Cancer is
Multiple.
many diseases under one
Yes.
word. Right? And so your cancer subtype, or the things that drive your cancer to grow, the targets for blocking, for therapeutic interventions, those targets can change over time. And so if you're facing a recurrence, it's important that your doctor actually takes that into account and helps to explore what the new targets might be. Like, it's a whole new ballgame. We don't just assume that it's a recurrence. I've had 3 conversations this week already with my pathologist about recurrent cancer. And is this really the same thing, or could this be something different? How do we know, so we can come up with the right drug targets and the right treatments? And so what I hear you saying is, I hear you saying that on BC Navi, that there is a place where patients can go, newly diagnosed people can not only get information, but also can receive checklists and ways to be able to track that they're getting the standard of care.
Yes.
I hear that there is an accountability buddy or a coach who can guide you
Mhm.
through understanding your diagnosis and your treatment. I hear you saying that there is a place for your caregiver, for your person who's going to be going on this journey with you, for
Yes.
them to go and for them to be able to learn about this cancer journey, because this is new for them too.
Right.
And all right, so we got a question in the chat though.
I got one more.
Go for it. What you got?
We just launched our movement. And
trials.
on our website, whenwetrial.org, and I just put it in the comments, you can find everything you need to know about a clinical trial, links to more information, and links to trials, because it's really hard to navigate that whole area.
Mhm.
So we try to break it down and educate people, provide the tools they need in a very simple way. And when it's funny, because when you go online and you Google clinical trials or breast cancer, they always talk about Black women. Oh, Black women, this happens to Black women, whatever. So we changed the whole game on that and talk about us. And so all the language on whenwetrial.org is about we and us, because we're talking to each other.
Love it.
We're trying to do Black girl magic and talk about us. Like, I don't want to hear about the we and the those and theirs. I don't want to use those pronouns. I want it to be relatable to who we are, our sisterhood, our breastyhood. And so we worked really hard to make all the language and everything available. So we have the tools. Between Jamila and I, you have everything you need to know. Right?
Well, now I got a question. Something we haven't talked
about
about yet. I got one. So for family members, advocates, partners, loved ones, what about support groups? Where are the places that they can go to find who their networks are, virtually or locally in person? Is there a place that lists the different support groups and what's available?
No, but actually the way that we help folks with that is we figure out what type of support group would they benefit the most from. Is it by phone? Is it in person? Is it by virtual? What do they need, that group support? What works for them? And then based off of where they are in the country, your coach or patient services can help you. We first try to start off with your local cancer center. What resources and support groups are available there? And if that's not available, then we work our way out. Do you need to have some support group in person locally in your area? Or are you more so inclined to join by the phone, or would you like to do a virtual group? And we'd actually do the legwork for you to help you find, that support resource that you need.
Yeah, we also do a support group, every first Saturday of the month on Zoom, called Touch Talk. And I'll put the Zoom link in the comments. So we never know who's going to come. We never know what we're going to talk about, but it's really just a place to talk. And we usually have a couple of spiritual leaders there. Dr. Regina came last week. And so we never know who's going to show up, but we try to provide this. But to your question, even Mo, one of the things that we think doctors can do a better job at is tell patients about us.
Right.
We're here.
Do it
This is
all.
what we do. We
I
are
love it.
advocates. And so if, if the doctor said, call Ricky, call Jamil, here's the website, here's the
Yep.
app, here's whatever, that's another resource for the patient and we can give them something that no doctor can. I mean, we love you, doctor, for what you do because you're cutting the cancer out, but the breasty love thing, it's not a club that you want to be in. I don't recommend it, but once you're in it, we have unconditional love for each other. And we do everything possible to help our breasty sisters. That's what we're here for, right? That's why we're alive. That's why
What are some of the areas for improvement? Let me ask you that. And I'm also putting in different advocacy groups. I think LBBC has a page where they list all the different advocacy groups. I know that Tiger Lily, I put Touch. I'm putting Chrysalis Initiative.
PCO, breastcancer.org.
Breastcancer.org also has a list of different support groups, Sisters Network, you name it. There are many, many organizations depending upon whether it's male breast cancer, whether or not it's it really depends. So I'm one of the contributors for the National LGBT Cancer Network. So they have support services. What are some of the areas that we can improve, or some things that you want to see a little bit different? One, from our organizational standpoint and our advocacy work, and then two, give people watching some hope. We've painted a somewhat grim picture here about the multifactorial source of disparities and how it's a Medusa. You cut one head and there can be two more that sort of spring up from it, right? We've talked about the paucity of participation in clinical trials, less than 3% is dismal. There's a lot of bad news here. So I would like for us to do two things. One, where do we want to improve? Your organizations, where do you want to move the needle to next? Where's the room for improvement? And then two, what's the hope? What's the good news from this?
Well, to me, I find I'm encouraged. I don't look at it as, and I'm a natural optimist. So maybe that's why I'm an April baby. So we're natural optimists. But I would look at it as like it's multi-pronged, right? So that's the reason why Chrysalis, for instance, we focus on participating like campaigns and efforts like More Than Words, because that's the non-diagnosed patient population, to get breast cancer on Black women's radar so that they can understand how they can reduce their risk and understand what to do to navigate a breast cancer diagnosis if that happens, and how to have those conversations. Then you have breast cancer patients, ones who have an active diagnosis, and we provide that wraparound support to make sure that we improve their health literacy and that we can intervene if those challenges come, to make sure that they have quality standard of care and to keep them on that, right? And then you have I think what I would like to see more of is less dumping of resources and information just on patients, but to have more accountability structurally, systemically, cost-wise, investment-wise, within the structures of our health system. So that accountability, the agencies that dictate reimbursement and being compliant, right? So equity should not just be met by the number of Black and Brown patients that you're seeing or serving, or the ones who happen to be accessible to your location. But when it comes to outcomes, when it comes to treatment, are we seeing that there are still disparities in those outcomes? Are there differences in the treatment and the care that those patients are receiving? And so more accountability for that, not just the number of Black and Brown patients that you have participating in the clinical trial, but what efforts are being made to make sure that the care is being equitable, that their needs are being met, and that there is that equity across the board. So having that built in, where the same way we have the equity assessment tool, we can drill down and focus on where those disparities lie, having that part of just what's built into hospitals. So instead of just having a town hall or a quarterly implicit bias training, but really focus on why is it that our particular Black and Brown patients are not receiving the same care, or what are the contributors to those outcomes beyond the social economic issues. So meaning not just attributing those outcomes or disparities due to poverty or lack of insurance, but meaning that if that is a barrier, you address it. That's comprehensive cancer care, but making sure that also the treatment, as far as what meeting the standards are, is being met, right? And just having that accountability there, having that support there, and then we can see all of these outcomes improve. I think that's what we need to do in order to move the needle. Very similar to what we did with maternal health disparities in this country, right? We said, you know what, we have some racism and underlying bias going on here. Let's make sure that we can address it and invest in it. We have to do the same thing when it comes to breast cancer.
Yeah. So I would, that's all so wonderful. You're so right on. I think that I was talking to Congressman Robin Kelly's legislative person on health the other day, and she used some really great words because they just put out a bill for clinical trial diversity to get really basically the FDA to be make people more accountable to the percentages of participation. And I love these words, and they really apply across the spectrum from treatment to access, whatever. Everything should be specific to the disease burden on the patient.
Right.
So I always say, you should be commensurate with our population, but it's worse. But I mean, the numbers that I want to change, Mo, you say, what do we want to change? I want to change that 41, 42% mortality rate difference.
Yep.
I want to change that 71% mortality rate difference for breast cancer, patients like me and Jamil. I want to change that 39% higher recurrence rate. I want to change the numbers for the fact that Black women under 35 get breast cancer at twice the rate and die at 3 times the rate. I want to change those numbers. And I really do think all of these factors are in play. And clearly, I love how Jamil is focusing on the present and focusing on making the system better and focusing on getting the right care, because we need that. But I'm trying to focus a little bit on getting pharmaceutical companies to do the right thing by the research, to get the FDA to do the right thing by the research to advance the science. But what does that take? That means energy and focus around what needs to be done specific to the disease burden on Black women.
And they're both so necessary though, Ricky,
Yes.
because,
Yes.
so much of what we do and say puts the responsibility on the patient, right? Who's already sick, who's already worried, who's already frustrated, to say, okay, now here's a checklist. Here's things you got to watch out for. Here's stuff you should ask about. Here's more, here's more, here's more. And, what both of your organizations are doing are really moving upstream of that, right? You're moving upstream saying, you know what? No, where's the follow the money? Cancer is $1 billion industry. Where are these billions going? And are they impacting the people who need it the most? What are the structures in place? And are they just fair? Can we just start there? Are the structures fair? Are we even asking the same questions and offering the same stuff to people?
I think people are good with safe. They wanted you safe. Nobody wants to say the racism part out loud.
Right.
Nobody wants to have anything controversial. And so
I want to move the needle to more inclusivity, right? What about our queer population? What about our LGBT folks with cancer who get asked their family members, well, who are you to them? Are you related to them? Maybe they're chosen family. Maybe they don't want to wear a pink gown. Maybe all the intake forms are not appropriate for them. My hope as we talk about moving the needle, we all need to move our organizations in that direction, because sometimes we get lost in our faith-based practices as well, which can be exclusive and not always inclusive. And I think that making sure that our sisters who are wearing burqas and saris and who are Buddhists and who are gender non-conforming and non-binary, like there's a whole world of folks who are just outside of the pink that we really need to begin to address in our organizations, in our communities, because other communities,
they're not going to get it.
They're starting to do some of that work, but in the Black community, we got a lot of isms, and we need to begin to move that needle in that way too. That's my hope, is that we're going to move. As we move, we all move together, right? In our community and in our beauty, our rainbow color beauty.
Yeah, and the time is now. The time is now. I mean, it's on the table, and I believe that we have fought like crazy to get that seat at the table. And I am staying in that chair. I got my plate and my forks and my, when you don't know which fork to use, I got all the forks and the glasses. I am not losing that place at the table. I got my own placemat, and I'm going to stand here until we get shit done.
One story at a time.
One day at a time, 1 minute at a time, one success at a time. But I think that I do have hope that the world is listening. I do believe that pharmaceutical companies are listening and hearing us. I do believe that even the legislative side is trying to, and we're trying to hit that side as well now, which is a kind of a new area for touch, but I think it's really important because we have to hit every angle. But I do have hope that we can take advantage of this time. I don't know how long it's going to last, so that's why every day counts. That's why I don't sleep, because I don't want to lose the window, right? And
not squander the opportunity.
Right.
I think the other part of it is that, there is room for you. If you're watching, trying to figure out where you fit in, whether you're newly diagnosed, whether you're a survivor, a thriver, a metavivor, whatever you call yourself in whatever category you think you fit into, or no category at all, there's room, one, for your narrative, for your story, because nobody's talking about these things and telling your story the way that you tell your story, because we
Right.
relate to each other. Breasties relate to each other, right? And to their stories. And when we did clinical trials that looked at who did we learn the breast exam better from? Was it better from a doctor, from a nurse, or from another patient, a breast cancer survivor? And guess who it was, right? It was from a breastie, the best exam, the best advice and things. And so getting empowered, sharing your story, getting involved, right? If your organization is watching, you're trying to figure out, well, where do I fit into all this? This seems mammoth. There is room for you in this movement. And you know, this isn't the sort of thing where there can only be one organization and one group that's doing this work.
It's
There's
all,
so much work
oh
to
no,
do.
we have a sandbox. You know, I have, you know, I love my sandbox. And I want everybody to be in my sandbox, or it's our sandbox. Like, no one fights alone. Not one of us can solve this problem alone.
Right.
And I really, you know, I cherish our relationship with Jamil. I cherish, you know, the partners that we could bring into this party, that we all have to do this together and support each other and you know, use our lane, but keep those windows open so that we have an expertise and a focus, right? That's going to get to a goal. But I think we need all of the focuses to work together to get us to better outcomes for Black women. And so
one last question.
Work together.
What about educating young people? For
people,
you know, the daughters, the family members, the kids, right? Because we have a question in the chat that says, you know, years ago, doctors used to teach the self-breast exam to people, right? And now, how do young people learn about this? And I'm typing a response that says, sadly, there's even controversy regarding whether or not to teach self-breast exams anymore, which I think is deadly. It is a mistake, right? And so you've got to use these organizations and reach out to us to connect to your young people before they get cancer, so we can talk about breast health, so we can talk about mentoring, so we can talk about this pipeline, right? All of our organizations are connected to pharma, and it's great. Pharma sponsoring interns, but the next part of that intern sponsorship is going to be pipelines at the bench and research and public health, and really filling in those gaps through those funding mechanisms. So stay connected with us on that, because that too, I think, is the next wave of this, so that it's not just one Ricky, but guess what? There's 30 more, and guess what? There's 20 more coming out of grad school, getting their MPH, and there's 10 more Jamils coming out of, you know, medical school.
And right. But no, we're actually hiring our next group of interns. If anyone knows an HBCU student, sophomores and juniors, pre-med, pre-health, pre-nursing, pre-psych, emails. I put the email in the comments. Emails. We are hiring interns to start in the next couple of weeks. So we really believe that our young people are going to be that voice in the families to say, okay, mama, did you get your mammogram? Okay, grandma, what's her story? Okay, you know, okay, auntie, you know, did you have breast cancer, or were you hiding it from me? Like, all those conversations need to happen. And we know, you know, we had 15 last year. They were awesome. We're ready to do it again. So email us at info@touchbbca.org.
Absolutely.
So, thanks, Jamil. This turned into like a cheerleading session. I love it.
Love it.
Yes.
I just want to also, our lovely Linda Blount from Black Women's Health Imperative, her daughter is in labor. So she rushed to the hospital before the show, and we were just praying for them that they have a healthy birth, and she becomes a grandma.
Oh, congratulations in advance. Prayers are definitely sent for the health of mom and baby and the entire family. Jamil, you want to close us out with some comments and some thoughts? Any other websites we should follow? How can we follow you on social media? Give us the scoop.
And I put your email address in the chat, girl. So.
The chrysalisinitiative.org, bcnavi.com. And I just want everyone, I know it's a lot, right? But I don't want people to think that it's insurmountable, right? We have evidence-based solutions. You know, every little bit helps, and we can continue to move the needle. And like how Ricky said, we have so many organizations focused on this since the need is so great. We all have our levers that we have activated as far as how we're addressing disparities. So you can get involved however you feel, you know, is it in the non-diagnosed part? Is it students? Is it caregivers and partners, support groups? Is it, you know, patient education? Is it breast cancer patients? Is it at the health system level? There's so many different opportunities. Don't think that it's insurmountable, because we are seeing the impacts of the work that we're doing. Extending lives, erasing those gaps, erasing the line, as that's what we have as our campaign for BC Navi. So don't think that, oh my God, this is so great, this has been a problem for hundreds of years, we're not going to be able to address it.
No,
No,
we're fixing it.
exactly.
We're
So
fixing, we're getting it done. And you know, if you're confused,
Right.
call any of the three of us, you know, call me. I can get you to Jamil and Mo, whatever, you know, we will hook you up. That's what we do all day. We're waiting for the phone to
absolutely.
ring. Right.
True.
So we're all
Yes,
here
true.
to do that work.
Well, thank you for having me. I appreciate it.
Love you so
Thank you
much,
for
my
being
bestie.
here. We love you.
Love
And, you know,
both.
we
Yeah.
hope this has been relatable and reliable and real, is what we set out to do every single Wednesday night at 6
Yeah.
p.m. on blackdoctor.org. This show, The Doctor Is In, is directed particularly to breast cancer survivors, thrivers, patients, advocates, anybody in the breast
Family
cancer
members.
ecosystem, right, who has a stake in this thing. We want you watching. We want you sharing it with your family members, sharing it with your Facebook communities, because we all know somebody who's been impacted by this disease.
Yeah, we
We
do.
all do.
Yeah.
And there is much, much work to be done. So we thank you for joining us. We'll see you next Wednesday night.
Yeah,
Thank you
next week.
to our sponsors, right?
Yeah, next
the
week we're
Doctor Is
doing
In.
the love show. We're doing a love show. We've got 4 like love couples to talk about how they did breast cancer, you know, together. And so it's really exciting to talk about that. And we
Love it.
thank Genentech and Amgen for all that they do for us and all of our sponsors. We are so excited.
I want to
have
do a
them.
single show reciprocally though. Can we
Oh
do?
yeah,
We got,
we will.
we got the
We
love
that.
show. I want us to get the singles and talk about how they keep it spicy, how they date with breast cancer.
Okay,
When do
well,
they
let's
have those
plan, girl.
conversations? So, you know, if you are single with breast cancer, we want to hear your story as well. Please reach out to us so that we
We
can
got
invite
you. Email us a story. Email us, you know, Ricky
Yeah.
at Touch BBCA. Email us a story. We'll plan it. Let's put it on the calendar.
Absolutely.
Let's do it.
This is for
We
you.
got it. This is for
All right.
you.
We love you guys. The Doctor
Love
Is
you.
In.
Breasty love. Breasty love. Happy Black History Month.
Take
Breasty
care.
love.
Bye.
Bye.